Thank you, and thanks for giving me this opportunity. I was talking at lunch about how I was going to describe my role, and it's part of the Late Career Researchers Forum. People who have got the advantage, or you may not think so at the end of this, advantage of having a long period over which to look at what had gone right and what had gone wrong, what we had learnt from this. I used to work with a historian who kept saying, don't say you learn from history. What you do is you learn from learning from history, you learn how to learn about the present. And I hope that some of the exercises that I'm going to be talking about are about learning from our past mistakes and past successes in terms of how we then think again about the way we do things in the future. But I want to, I don't want to go there. I do want to go here, yeah. I'll start off with a couple of health warnings. The first, some of you may remember this man, I think he's still alive actually, but he was governor of Hong Kong after he stopped being a Northern Ireland minister. And the only words he said to me on my first meeting with him was, of course, I did not read this undoubtedly worthy document. I had produced for him what was an undoubtedly worthy document, full of useful insights that were going to change the nature of policy in Northern Ireland. But of course, he didn't read it. But I also want to give a clinical warning. Now, those of you from Northern Ireland here, can anyone shout out who this picture is? Does anyone know who this picture is? Sorry? Dr. Love, you're absolutely right. It was Dr. Love, a man who I had a huge amount of respect for. But the first time I started giving an opinion to him, his reply was, I think you'll find the correct answer is. And he said almost exactly the opposite. Now, he was in many ways a first-rate clinician, but with something of a James Robertson Justice sort of confidence about the way that he expressed himself, with the advantage you could then exclude any evidence from the discussion if it came to that. So I want to think a little bit about, first of all, about being useful. And I make no apology now for saying a lot of very obvious things, because I think saying obvious things is a little bit like common sense. It's not very common. People don't actually often stop and think and say, what are the things we're trying to do? The first part of this is understanding the problem, and I'm going to talk a little bit more about understanding problems, but one of the things we get wrong so much of the time is we don't actually know the question we're trying to answer. We've got solutions desperately in search of a question, and we're very good at giving the answer, but we're not very good at working out the question that's related to it. We're all very good at specifying the research question. Actually, we're not all very good at specifying the research question because the research question is unusual. It's unusual for it to be a tidy, easy relationship with the worry we have. We have to develop the evidence, and we'll talk a little bit more about that in a moment. But perhaps more importantly, we've got to understand the evidence. And I want to talk a little bit later on about the problem of understanding our evidence and reviewing it, and then applying it. And so that's all we've got to do, really, to be useful. But the reason I'm not asking you to look at any of this and make any judgments or anything about it, but I love data because data often tell you things that you didn't know before. And this is a picture of the future population in the Republic of Ireland, 2025 against 2055. And you suddenly see it's not just the population's aging, it's aging in a particular way. There are particular age groups that are growing much more rapidly than others. And there are very different patterns appearing there. And here we've got the age at death. And how is age at death changing? And you can see there, if you compare the 2016 to 2046, there's going to be more than doubling the number of people dying over 85. It's not just the population's aging. And if anyone in this room has today, I will forgive it if you did it today, but if you've ever said the population over 65 is rising, you should be ashamed of yourself. because that contains almost no useful information, except how many people are over 65, because it's the patterns, not the overall proportion, that really matter. And that's why I say, understand the problem, understand the questions you're trying to ask, because very often, if somebody had put in here what is happening to the population over 65, there would be a very uninteresting number there. If you look at the details of what's happening, you get interesting numbers. And when we're thinking about needs for palliative care, it's not just about dying. And I show this. This is work, this come out of work that Peter Mays led. I just have to preface everything I say here. I've done a huge amount of work on a huge number of studies, but other people have done much more than I have done on these studies. And I'm just taking the credit because I was the person who was allowed to take the credit. But if you look at this very simply, what Peter Mays' analysis is really doing is showing that the number of people dying with palliative care needs is rising, but the number of people living with palliative care needs is rising much more rapidly and much more dramatically. Again, we've really got to learn to step back and think about the problem more clearly, because we very often don't think about problems clearly enough. And that's part of the reason, but when we give answers, nobody recognises the answer being an answer to a question that they're really interested in. And we often complain, quite rightly. I know there are some policymakers and people with those sorts of roles in the room here. We often complain about how people pay no attention to the research. But if the research isn't answering their questions, then it's not surprising they don't find the answers interesting. So I just want to think a little bit about how we specify the research question. And very often a good starting point is, what will happen if we do nothing? And what do we really mean by doing nothing? Do we accommodate the changes in the background, or do we ignore the changes in the background? What will happen if we don't do anything about this problem? Does the current service provision produce good outcomes? Well, we can be very proud, I think, that Ireland is way ahead of most European countries and most countries in the world in terms of the commitment to palliative care development and support and the service quality and all the rest of it. But we've also got very good evidence that half the people who die in Ireland die with their relatives thinking they were under-supported, that they could have had a better experience. Now, I find that quite a sobering thought, that we are doing much better than others and we're not doing nearly well enough. But, let's look at what we're doing at the moment, and is it producing the outcomes we're really looking for? And is the current service good value for money? I was interested that the government in the Republic is only having to find an extra $3.5 billion this year for the health service, because they had underestimated in the budget by about that amount. But what I thought was interesting there was really the question of, are we getting good value out of this money, is talked about a lot and researched and acted on very little. And we really need to be much more interested in, is the current service good value for money? And one of the things that I find really depressing and difficult is that we are spending huge amounts of money on a very small number of people. And the evidence is suggesting this small number of people are not having a good time. So a small number of people, a small proportion of the population, represents a huge proportion of the costs of healthcare. And yet these people, in general, their families are reporting that those outcomes were not good. There are other questions that are entirely relevant, and I'm going to talk a little bit about this in one of the examples I give, but does a new treatment or service work? And does it work well enough? And we're very familiar with drug trials, and I thought it was actually quite interesting, a question that was very appropriately raised about the evidence on advanced care planning earlier on. And I don't have a strong view that suggests that Sean Morrison's right and anyone else is wrong, but except if he's buying the next round. But that question, I think, how do we get evidence in areas that aren't as nice and clean cut as does a drug work or not? And then, of course, when you get onto a drug, does it work or not? Actually, that turns out not to be a simple question either, because does it work in particular circumstances for particular people with particular problems? But it's one of the questions we have to get better at is there is a new treatment, does a new treatment work? And if it does work, does it work well enough? So that gets on to, as an economist, I had to show at least one picture that you wouldn't like, and that is the cost effectiveness plane. This is very simply translating onto a piece of paper the dilemma that we've got 4 possible outcomes from any treatment or new treatment. Either it's better and more expensive, it's better and cheaper, it's worse and more expensive, and it's worse and cheaper. And those 4 outcomes are relevant. Now, most of you in here, I think, when you hear worse but cheaper, do you get, oh, well, we must look at that in some detail and really think this through, see if we can get ourselves into a position where we say, yes, it's not going to be quite so good, but it's going to be so much cheaper, we'll do it. Have any? Mind you, every one of you in this room has done that in your shopping this week, if you don't have a spouse who does the shopping for you. My wife has the advantage of having a spouse who does the shopping for her. But we all actually make that judgment all the bloody time. We keep saying, it's not quite what I want, but it's so much cheaper. And that's really good value. Does anyone deny ever having said that when they go shopping? Good, because I don't like to see too many liars in the room. But the point there really is that we should actually be enthusiastically looking at, does the change make things worse and more expensive, in which case don't go there? Does it make it better, but it's more expensive? Maybe, if the extra cost is worth it. Does it make it worse but cheaper? Maybe, but less likely than if it makes it better and cheaper. And does it make it, whatever the other one is, I can't remember, because I'm now over 65. You're not allowed to say how many of us are that. So let's think a little bit about creating the evidence. And this talk is all about evidence into practice. But the reason I use this as a question is, it's okay, well, I'll be well hydrated. Mary will be pleased because well hydrated is good, isn't it? Well hydrated in hospital is good. Well nourished in hospital. Getting on your hind legs and walking down the corridor is good. We've got good evidence on those. Anyway, I won't divert onto rehabilitation, even though it's in my job title. Developing the evidence and understanding the evidence. Who here thinks that we've got a hierarchy of quality of studies? You start with randomized controlled trials, blinded, double-blinded. Is that wonderful? Of course it's wonderful if you can do it. I actually, for 3 years in my life, I was in the office where Bradford Hill first worked. Do you know who Bradford Hill was? That is the trouble with the younger generation. Bradford Hill was essentially the person who defined controlled clinical trials and did the statistics for it. He was a statistician and an extraordinary man. And when I sat in his office, I felt the walls giving me all this propaganda about controlled clinical trials. But I'm not that sort of person. So I do controlled clinical trials, but I'm interested in horses for courses. How can we make sure that the design of the study is one that's actually going to give us insights into the problem we're dealing with? And how are we going to learn to enjoy the insights even when they don't give us this 100% certainty that we've done a study that is as robust as is conceivable, because we've only done a study that's as robust as is possible. And that's, I think, an important difference. And many important policy and practice questions are not researched because it's difficult to do studies that follow all the right rules. And most of us in here, has anyone here never had a research grant proposal refused, rejected? And has anyone here felt really unhappy because you had a really good proposal and it bombed? Yeah? Everyone here agree that's been an experience they've had? And very often the reason for that is you did your very best to try and get your head around what was a research project that provided insights into that question, but it didn't look tidily the sort of research project that was going to fit all the tick boxing that people go through when they assess this. But I think it's really important for us as researchers to be very robust, that the robust study is one that is fit for purpose. And it's not simply it has these particular characteristics which give you the most satisfactory statistics at the end of it, the most satisfactory policy recommendations that are based on the most satisfactory statistics. And very often research orthodoxy has not been built around some of the really interesting and complex questions. Does anyone know of this huge body of literature about how best to manage people with multimorbidity? Is there a huge literature out there that really gives us insights into how to manage people with complex multimorbidity? Of course there isn't, because that's really difficult stuff to do. It's really difficult because people go around having rather individual mixes of diseases. If only they could be guaranteed to have the right portfolio of diseases so we could put them into nice studies. But they won't do that. They keep on being sick in their own ways. And they refuse to cooperate with what would make research easy. The answer to that is not to say, let's run away and hope that nobody notices we're not doing this work. It is to try and sell to people the idea that other kinds of studies, not necessarily randomized trials, not necessarily even case-controlled trials, not even well-designed observational trials, will nevertheless give us some useful insights that may help us to develop better quality of service. And I feel very strongly that part of the fault is from the research community that has bought the, what I call, don't allow evidence to be EBM'd out of existence. Of course we want evidence-based medicine. Of course we want the best possible studies, but we also want the studies that make the best difference. And sometimes that's going to be rather messy types of work, which produces slightly messy results. Now, I want just to ask my banana question. You've all got to vote on this. Anyone here think they're quite good at buying bananas? Do you? Yeah? You're all very shy people. You probably haven't bought a banana recently, so you can't remember. If you buy a banana, you go in there, you don't say, I'm going to sample 46 bananas here before I choose which bunch of 6 I'm going to buy. You look at it and you say, yellow but not too yellow, not too green. If it's got too much brown on it, no, I don't think I'll have that one. Is that how you buy bananas? And you pretty much get it right all the time. There is that odd day when you get home, you open the banana and it's got a whole lot of brown inside and it shouldn't have, and you're very unhappy with that. But that's quite rare because your evidence on bananas from simply looking at the colour of the skin is pretty good. It's good enough that you actually are quite happy to live your life with that. Now, an awful lot of questions we have, even complex clinical questions, actually we should be pretty happy that if we think on balance this is going to be quite a lot better than what we do at the moment. It's not simply to say, unless we can show that once in 20 we would, not more than once in 20 would we be wrong. Because I've been wrong on bananas more than once in 20 probably in my life, if I did the study on my buying of bananas weekly for the last 60 years. Then, but nevertheless, I'm quite happy to say that evidence for this purpose is pretty good. And I think we've got to be much more robust in saying sometimes the best possible evidence is evidence that doesn't meet all the most stringent requirements, like not being wrong more than once in 20. If we all lived our lives not being wrong more than once in 20, most of us would have dug a hole and jumped into it by now. So I think we've got to teach the recipients of research as well as teach the researchers to think what is the kind of evidence that is reasonable and acceptable to answer the sorts of questions we've got. Because otherwise we won't answer the questions at all. And that, I think, is much worse. And the world is not dichotomous. And anyone here who has been fortunate enough to have me advising on their PhD can put their fingers in their ears at the moment because they're so fed up with me saying that we should always be interested in the world being continuous. It's full of continuous variables. It does not have a lot of discrete variables. Just like poor Samantha's need to work out how many people need palliative care, well, actually, obviously, that's an important question, but it's also a nonsense question. It's a nonsense question in the sense, but what do you mean by need? Because some people, 20 minutes once every 2 years would be good. Another person, it's going to be a huge proportion of their time will be interacting with palliative care services. And I'm not criticizing what Samantha's done there. I think it's really useful. But it's that the problem is the world is not dichotomous into you need it, you don't need it. It works, it doesn't work. It tends to work more for some people than for others. It might work quite a bit. It might be very good value because it works a little bit and it doesn't cost very much. You know, all these different things are in there. So, if I can... I want to say a little bit about reviewing the evidence because everyone in here has done reviews, systematic reviews, pragmatic reviews. It's rather like being an American. You have to have some title before it. You're an African American or an Irish American or something. Any review has to be a systematic review or a pragmatic review or a narrative review. But I think we do need to think a little bit more about how we review the evidence that's out there, because sometimes when you're reviewing evidence, you can actually make that evidence an awful lot louder. And people who do meta-analysis and work of that type, where you're trying to combine the numerical or qualitative findings from multiple studies, will know that sometimes pulling those different studies together and actually using their data or using their findings can make it much more powerful. I talk about this because May, Norman, Castle, and associates, anyone who could spell their name was allowed onto that paper. That paper was interesting because we took a group of studies which had all shown nothing. And when people previously put them together, they showed nothing. When we reanalyzed their data, they showed something. And what happened there was they'd all set themselves a set of analysis rules when they set up the study, which were absolutely what was approved by all the journals, all the reviewers, all the assessors of the grants, all the rest of it. But actually, they had done something really stupid in the rules that they'd set themselves, which meant you would never find the answer, because they had said, we're not allowed to ask any additional questions other than the ones we had asked at the start. But they'd actually all produced data that allowed you to ask other questions. But we were lucky because we were not implicated in any of these original studies, so we could ask whatever damn questions we liked. And we found a fairly powerful finding that people in American hospitals who see a palliative care team and have cancer are likely to cost $10,000 less per stay than those elsewhere. Now, I think that's actually quite an interesting finding. It suggests that they're reducing unnecessary and inappropriate care by quite a lot, and you're giving someone an experience that is not nearly so bad. And even in that wonderful institution down the road from where I live, St. Vincent's Hospital, where we did a study there, we showed that if you assess people's needs more formally and more properly using a multidisciplinary team, you have very similar results to what we found in that paper. But we only knew it was there because we were able to review that evidence. Sorry, this has gone ahead without my permission. Sorry. The only reason we were able to find it was we weren't stuck with rules that people had set themselves, which were wrong rules. And I give the other study there because I knew Samantha would be in the audience here, and she did most of the work there. But the other thing to know about reviewing the evidence is you get an awful lot of citations, and I can really recommend it. If everyone's wanting their H-index to go up, do a few good reviews. But I want to talk a little bit about then applying the evidence. Well, the first thing, we always remember that things are complicated, and the question is, do you oversimplify or do you embrace the complexity? When you oversimplify, you can give people much clearer answers, but they're not usually so useful. When you embrace the complexity, you've got to bring people with you to help them to understand why that complexity makes this an interesting way of looking at the findings you have. Evidence on treatment is often affected by multimorbidity, and yet most of the studies we have on the effects of treatment ignore multimorbidity and therefore actually give you almost no insight that's interesting. Evidence can be difficult to describe or communicate because inherently humans are complicated animals that it's difficult to work with. And some commonly used research metrics are only partially useful. Most of you who have seen any health economics articles will be very familiar with the quality adjusted life year, often using the Euroqual EQ5D, 5-dimension or 3-dimension instrument. You've all probably heard of those sorts of things, which is in many cases a very useful measure. But what we found when we use it in the area of palliative care is that it only measures well if the intervention has a very clinical effect rather than a more social effect. If it's got a more social effect, it really doesn't measure what we've got. So sometimes we have to say, well, the tools that are commonly used are not actually terribly useful tools. And we are aware of the fact that a lot of people are still getting high-cost, low-value care because we don't really know what to do with people who have those complicated needs. The other thing to remember is evidence is a slow burner and may affect provision over a very long period. And you mustn't be too depressed by the fact that nothing much happens in the first instance. You know that awful thing, I found a great insight, nobody paid attention. I've got one example in my life of a study that within a year the world had changed. And it was on the screening for retinopathy of prematurity in newborns. And we were able to show we could save a lot of money and find much more disease. And suddenly the Western world changed. I tell you that story because I've done a lot of studies, and almost all of them were not nearly as spectacular as that because they were trying to answer complicated questions. Now I want briefly to talk about a few areas of work and what has been the successes and failures of trying to apply the evidence to policy and practice. As I said, we've done a number of studies that look at the effects of palliative care-led decision-making, better decision-making on outcomes and costs. And I've already said some of the studies in this area were of relatively poor design, but what we were able to show here was better decision-making really works. Better decision-making is really good. It's really useful, and it's particularly useful where people have complex disease, and it's particularly useful where people have cancer and complex disease. And what we've been able to show there, I think, is beginning to filter into the thinking, but we still do not have multidisciplinary teams assessing people going into hospital or people who have got complex needs who are referred into general health services. The evidence has been quite widely used in service planning, but I suppose one of the reasons it was quite easy to get people enthusiastic about that was that in many cases it saves money, and things that save money are easier to sell. But we've still got a lot of low-value, high-cost care, and so we haven't been entirely successful there. But I think this kind of evidence is probably very much slow burner, so I'm not too depressed about it yet. Last year, I was involved with this clinical trial, the Better B study, which was looking at the use of mirtazapine for people with breathlessness. And this study was really interesting because a quarter of all doctors in palliative care were using mirtazapine in this circumstance. And we found that it had no positive effect on symptoms. It increased the number of hospital admissions. It increased the burden on informal caregivers. And it lowered the measured quality of life. And that was a really nice study because it said, don't for God's sake do this. And we are beginning to see quite rapid rejection of this in the context of us actually having very little idea of what you do instead, except that doing that is worse than doing nothing. And sometimes learning that doing this is better than doing nothing it's worse than doing nothing is good. We were involved, I was involved, I'm not the only person in this room, but I was involved in a study called Dyadic that was looking at a psychosocial intervention for people, for patients and their caregivers, with people who were very sick, and this was based on an American intervention that had shown some results in these kinds of ways. And the problem here really was, first of all, it was a badly underpowered study in the end. But what it basically seemed to show was it makes very little difference for most people. But the crucial point is it did seem to make some difference in some circumstances for some people. And that's where I come back to saying, let's try and dig a little bit more into the evidence to try and understand where that's going. And you'll be glad to know my last case that I'm looking at is we've done a number of studies that show what patients want. And I was quite encouraged listening to some of the presentations earlier that we actually are engaging on some of the things that patients want a bit more. But it's very clear what people want from palliative care services and services, particularly near the end of life. They want support for unpaid caregivers, they want barrier-free access, they want continuity of care, and they want prioritizing clinical benefits over social benefits. And the evidence there is pretty good. And I'd say I've only been involved with that evidence for about 19 years, and I haven't seen the dramatic changes I want, but I hope we're going to see some slow burners. So just a few concluding thoughts. Unless you understand the problem, unless you design a research question that is appropriate, don't be surprised that people don't think you've solved any problem for them. Understanding policy and service priorities helps because you can then try and fit into it. And we were lucky enough with some of the work we've done to be able to work closely with those who are developing policy documents, and that's obviously a help. But also, doing really good studies helps. And even if that really good study isn't a really good clinical trial, really good studies help because people take it more seriously. But finding accessible ways of describing your findings when your findings are complicated is really a big challenge. And otherwise you will get the I have not read this undoubtedly worthy document. Working with key implementers clearly helps, and I've seen a lot of little bits getting into that. And the being patient helps. And that's one of the advantages of being a late career researcher. You've learned patience over a very long period of time. But the other thing that you should all try and cultivate in yourselves is being lucky. Because now and again, you produce the right paper on the right topic at the right time, and you become rightly famous. So have been paying attention. Thank you.